النهاردة هنتكلم عن الأسيد بيز and electrolyte disorder. مهم جدا إن احنا نعرف تفاصيلها لأن مفيش حد فينا هيشتغل في أي مجال إلا لما هيتعرض يا إما لحاجة فيها acid base disorders أو electrolyte disturbance. First, what's acid? Acids are substances that release the hydrogen ion, while base are substances that combine with hydrogen ion. النورمال pH بتاعنا من 7.3 ل 7.4. Any small changes في ال pH بتعمل major disturbance لأن most of the enzymes بتfunction within very narrow range of the pH، وإن ال acid base balance بتأفكت الإلكترولايت زي الصوديوم والبوتاسيوم والكلورايد، وده هيبان بالتفصيل لما نخش بعد كده في ال disturbance. Also changes في ال pH may affect the hormone وال membrane function and alter in the protein. We have two types of acids inside our body, either the volatile acid or the fixed acid. The volatile acids come from the combination between carbon dioxide and water, while fixed acid come from the lactic acid or ketone bodies, sulfuric acid and phosphoric acid. The origin of the base come from ammonia, sodium citrate and sodium lactate. As you can see, we have much more acid inside our body if compared to the base. So we are in continuous state of being in acidotic range. The body uses the three mechanisms to control the blood acid balance. Either the acid base buffer system from physiological point of view, or using the respiratory center, or using the kidneys. The acid buffer system. There are three types of the acid buffer system, including the bicarbonate buffer system, the phosphate buffer system, and protein buffer system. Actually, they are very weak and last for a very short duration. What about the respiratory center? The respiratory center is located in the brainstem and it controls the hydrogen ion concentration by regulating both the rate and the depth of the breathing. With acidosis, the respiratory center will increase the rate and depth of breathing, and with alkalosis, the respiratory center will decrease the rate and depth of breathing. Well, characteristic pattern of breathing for the acidosis is known as cosmal breathing, which is rapid and deep. The respiratory center will start functioning after the physiological buffer system has been stopped, but actually it will last for a short time and then fatigue will develop. Then comes the role of the kidney. Nephrons of the kidney can regulate hydrogen ion concentration by excreting excess hydrogen ion in the urine. This is one mechanism. And another mechanism is by reabsorbing of the filtered bicarbonate or generation of a new bicarbonate. That's why in patients with renal impairment, the kidney loses its role in regulating the pH of the body and in keeping normal pH, as long as there is no urine excretion by these patients, and so no hydrogen ion will be excreted, and the ability of the kidney for reabsorption of bicarbonate or generation of new bicarbonate is being affected, and so these patients are in continuous state of metabolic acidosis. هنا بنشوف ازاي ال different mechanisms اللي بيكنترول ال pH وال hydrogen load inside our body. أول حاجة بنلاقيها هي ال extracellular fluid، فيها ال buffering systems اللي اتكلمنا عليهم، وفي رول كمان لل red blood cells through the hemoglobin، والأكشن ده بيتم immediately لما بيحصل change في ال pH of the body. This should be kept in consideration. العيان يكون مش anemic. Then come the role of lung through the respiratory control, either by expiration and wash out of carbon dioxide، ودي may last for minutes، وبعد زي ما قلنا قبل كده ان العيان ممكن يحصل له fatigue بعد شويه. نيجي في الرول الثالث ال intracellular fluid mechanism، وبيحصل exchange between الهيدروجين ion والبوتاسيوم ion. كلنا عارفين ان البوتاسيوم ال high concentration بتاعته intracellular if compared to the other electrolyte like sodium for example. Whenever the hydrogen ion load increase بيحصل exchange through which بيحصل shifting of hydrogen ion from extracellular to intracellular with jumping of the potassium ion from intracellular to extracellular، وده اللي بيديني relation between acidosis and the developing of hyperkalemia، ودي ممكن تاخد hours. الرول اوف ذا كيدني اتكلمنا عليه وقلنا ممكن ياخد دايز. في رول للبون بيطلع من خلال اللي هي الريليز اوف بون سولز. كل ما يكون في اسيدوزس كل ما هيحصل ريزوربشن للبون سولز، وده بيبقى very slowly و take a very long time، وده اللي هيدينا في النهاية الكرونيك ميتابوليك ديس اوردر patients اللي بيديفلوب رينال اوستيوديستروفي. عشان كده في الستيجز بتاعة الرينال impairment اللي هي stage 3 and 4 we start to treat this metabolic acidosis to guard or to delay the development of the metabolic bone disorders اللي العيان بتاع الكرونيك renal failure بيشتكي منها بعد كده. هنا دايجرام بيبين لنا ان انا لما بقابل حالة acidosis او alkalosis وعايزة اعرف هل هي metabolic ولا respiratory ابدأ افكر ازاي. اولا ببص على البي اتش، لو لقيتها اقل من 7.3 يبقى انا بفكر في اسيدوزس. اول حاجه ابص عليها على البايكارب، لو اقل من 24 ملي ايكويفالنت most probably في metabolic cause of acidosis، ومتوقع ان يحصل compensation by respiration من خلال ان هو يبدا يقلل البي سي او 2 من خلال الهايبرفنتيليشن. On the other side لو ال pH أقل من 7.3 وال PCO2 عالي يعني في retaining لكربون دايوكسيد أكتر من 40 ملم mercury we suspect إن ده respiratory cause of acidosis، وبنexpect إن الكدني هتcompensate من خلال إنها تزود البايكارب أكتر من 24 ملي equivalent either بgeneration لنيو بايكارب أو by reabsorption of the already filtered bicarb. لو ال pH أكتر من 7.4 يبقى أنا في كاتيجوري الألكالوزس. أبص على البايكارب، لو أكتر من 24 ملي equivalent يبقى ده metabolic cause of alkalosis and kidney will respiration will compensate through retaining carbon dioxide بحيث يبقى أكتر من 40 ملم mercury. ولو ال partial pressure of carbon dioxide أقل من 40 ملم mercury يبقى ده respiratory cause of alkalosis وهيحصل بعد كده renal compensation. ال EBG هو عبارة عن الارتيريال sample بسحبها من الارتيريال blood through the radial artery which is very safe if compared to the femoral artery، وببعتها للمعمل بيجيلي فيها الميجرمنتس بتاعت ال pH والبايكارب والأكسجين saturation والكربون دايوكسيد and sometimes other electrolyte، ومن خلالها بقدر أحسب للبيشنت الأسيدوزز أو الألكالوزز بتاعه. Let's start. Metabolic acidosis means excessive blood acidity characterized by inappropriately low level of bicarbonate in the blood. When you see a case of a metabolic acidosis, you have to think about the causes. It is either due to increase in the acids, and by acids I mean the fixed acid, through increase the source of the acid in cases of lactic acidosis with starvation أو ketoacidosis with diabetes and DKA أو with salicylate acidosis في overdose. We consider the generation أو intake of the acids to increase the source is a cause or important cause for metabolic acidosis. On the other side, the fixed acid may increase inside our body because of failure of its excretion. That's to say, in patient with renal failure. Or the metabolic acidosis is due to decrease the base through excess loss from the GIT with patients or with diarrhea or some kidney disease known as proximal and distal tubular acidosis, or consuming a large amount of the ammonium chloride inducing this metabolic acidosis. It has been found that the first category of metabolic acidosis for patients with increase in the fixed acids is associated of increase of what we call increased anion gap, and those causes of metabolic acidosis as a result of the decrease in the base is associated with what we call normal anion gap. What is anion gap? It is the difference between the positive and the negative cation inside our body. This classification is just for simplicity for the differential diagnosis of the causes of metabolic acidosis. The normal anion gap 12 plus or 2 millimole per liter, that's to say a range from 10 to 14. For classification of the metabolic acidosis, we either classify it into non-anion gap metabolic acidosis or the increased anion gap metabolic acidosis. For those non-ionic gap metabolic acidosis, it carries also another term, which is hypercholoremic metabolic acidosis, which may be due to the GIT loss of bicarb or renal loss of bicarb or others. For the GIT loss of bicarb, it may result from diarrhea, from the GIT fistula drainage, from urinary diversion to bowel. Whenever there is cancer bladder, you can divert the urine by inserting the ureter directly to the colon, or chloride containing drugs. If the cause is due to renal loss of bicarb, it may be a result from renal tubular acidosis, carbonic anhydrase inhibitors, or potassium sparing diuretics. Other important item is the parenteral nutrition of the patients. If you are not calculating well, you may enter the patient in the metabolic acidosis. The other group, which is increased anion gap metabolic acidosis, may result from ketoacidosis that occurs with diabetes, uremic patient with renal failure, salicylate intoxication, starvation, methanol intoxication, and alcohol ketoacidosis. What about the symptoms of metabolic acidosis? Usually there is no symptoms in the minor changes. The characteristic breathing of cosmal breathing or cosmal respiration is pathognomonic for the metabolic acidosis. Shifting of potassium out of the cell inducing the symptoms of hyperkalemia and increasing in the extracellular phosphate concentration. What about the cardiovascular effects? Depression of the myocardial contractility is very, very important symptom for the metabolic acidosis. Patients may have arrest due to this acidosis. Sympathetic overactivity with tachycardia, decreased arrhythmic threshold. A very important also side effect is the resistance to the effect of the catecholamine, peripheral arteriolar vasodilatation, venoconstriction, and vasoconstriction of pulmonary artery, inducing the pulmonary edema. Here we can see that there is a CNS effect of the metabolic acidosis through inducing cerebral vasodilatation and increasing in the intracranial pressure. On the long term, bone resorption may develop, and pathognomonic features of renal osteodystrophy will develop in patients with chronic renal failure having chronic metabolic acidosis. What about metabolic alkalosis? It is a condition in which the blood is alkaline because of an inappropriate high level of bicarbonate. As you can see, in metabolic alkalosis, it is either due to low fixed acid coming from excess loss of endogenous acids through the GIT or through the kidney. Through the GIT with the vomiting and gastric suction, and through the kidney comes from the potassium and chloride deficiency or cases of hyperaldosteronism and Cushing syndrome or the use of the diuretics. And if metabolic alkalosis is due to increase in the base, most probably increase in alkali administration, large amount of sodium lactate or sodium bicarb has been administered, inducing this metabolic alkalosis. Metabolic alkalosis can be classified into two types, either chloride responsive or chloride resistance. And we mean by chloride responsive that urinary chloride less than 20 milliequivalent per liter, and those with chloride resistance, urinary chloride more than 20 milliequivalent per liter. Causes of chloride responsive include post-diuretic therapy, vomiting or gastric drainage, villus adenoma of the GIT, bicarbonate administration, massive blood transfusion. And what about the chloride resistance? It is either with hypertension or without hypertension. For those cases with hypertension, primary aldosteronism, renin-producing tumor, congenital adrenal hyperplasia, Cushing syndrome may be the cause. And for those cases without hypertension, Bartter syndrome, Geltman syndrome, and the use of diuretics may be the cause. Symptoms of metabolic alkalosis. Also in minor changes we don't have symptoms, but with a wide change in the pH we may find irritability, muscle twitches, muscle cramps, and if it is prolonged, contraction simulating tetany may develop. Inhibition of respiratory drive via the central and peripheral chemoreceptor may develop. Depression of the myocardial contractility also and arrhythmia. Cerebral vasoconstriction leading to decrease in cerebral blood flow resulting in confusion. Shifting of hydrogen ion into cells leading to hypokalemia, and the manifestation of hypokalemia start to appear on the patient. What about respiratory acidosis? Respiratory acidosis is excessive blood acidity caused by building up of carbon dioxide in the blood as a result of poor lung function or slow breathing. What about respiratory alkalosis? It is a condition in which the blood is alkaline because there is a rapid or deep breathing resulting in a low blood carbon dioxide level. This was for the pH changes inside our body. What about the electrolyte imbalance? First, we will start with hyponatremia. The normal serum sodium is ranging between 135 and 145 millimole per liter. Symptomatic hyponatremia is associated with mortality of 10 to 50%. Hyponatremia may be due to the transcellular fluid shift which occurs when glucose, also mannitol and glycerol concentration في extracellular fluid increase. It will increase the tonicity in this compartment. This is rapidly corrected by water shifting from cells into the extracellular compartment, thus decreasing the extracellular sodium, producing hyponatremia. Or hyponatremia may be due to water ingestion in excess of loss, which will result in dilution of the body fluid by this water retention, and it is the most common cause of hyponatremia is due to either primary polydipsia, which is a compulsive water drinking occurring with some psychotic disorders, especially schizophrenic. Primary polydipsia can occur in patients with a neurological injury, for example, multiple sclerosis or meningitis or sarcoidosis. The urine of these patients is extremely diluted. البيشنت ممكن يشرب 7 لتر 8 لتر 10 لتر fluid. Severe hyponatremia also has been noted to occur with those beer drinkers. And a similar scenario may occur in elderly individuals who drink 3 to 4 liters of water and the urine is extremely diluted in this hyponatremic patient. Or the cause may be renal failure. Water excreting defects exist in anuric patients, and ingestion of water in excess will result in this hyponatremia. البيشنت مش قادر يخرج كمية الفلويد اللي هو أخدها، فبيتحول في النهاية إن في retention للفلويد ده بيinduce الهايبوناتريميا. diagnostic approach لبيشنت عنده hyponatremia. أول حاجة أقدر بسهولة إن أنا البوليديبسيا والرينال فيلير أقدر أعمل لهم exclusion. البوليديبسيا من خلال examination to the patients and the history from the family, والرينال فيلير من خلال اللاب findings through the urine والبلاد يوريا نيتروجين والسيرم كرياتينين. once ان انا استبعدت ال 2 causes دول ممكن اقسم ال other types of hyponatremia into 3 groups. either patients hypovolemic hyponatremic يعني hyponatremia with reduced extracellular fluid volume، أو hypervolemic hyponatremic يعني hyponatremia في edematous state، or eovolemic hyponatremia يعني hyponatremia in apparent eovolemic state patient. What about the hypovolemic hyponatremic؟ يعني عيان عنده hyponatremia و hypovolemia either occurs with vomiting, diarrhea and gastrointestinal blood loss or patient having sodium and water loss through the sweating، ودي بتحصل للناس اللي هم الالترا ماراثون رانينج بيجروا مسافات طويلة، او العيان اللي عنده uncontrolled diabetes mellitus عشان البوليوريك ستيت اللي عند العيان بتنزل كميات كبيرة جدا من اليورين containing sodium، فبالتالي هيبقى hyponatremia والبوليوريا عملت له hypovolemia. او ان عيان بياخد thiazide or loop diuretics او حد ادى patient osmotic diuresis بالمانيتول or during recovery from renal obstruction or tubular necrosis. بعد الريليز of the renal obstruction أو في مرحلة الريكفري في الtubular necrosis البيشنت بيخش في polyuric phase ممكن يديفلوب فيها hypovolemic hyponatremia or renal salt wasting which occurs in patient with adrenal insufficiency. What about the hypervolemic hyponatremic؟ يعني hyponatremia في عيان edematous. It is either congestive heart failure or patient with cirrhosis or patient with nephrotic syndrome. And what about eovolemic hyponatremia? Most probably with patient with syndrome of inappropriate antidiuretic hormone secretion or adrenal insufficiency or hypothyroidism. There is a term known as pseudo-hyponatremia usually occurs with cases with hyperglycemia. ده بيبقى artificial في الميجرمنت بتاع الصوديوم مع حالات الهايبرجلايسيميا يبان انهم عندهم hyponatremia despite انهم ما عندهمش hyponatremia. Signs and symptoms of hyponatremia. Generally patient with sodium of 125 millimole or greater ممكن يكونوا asymptomatic. أقل من 120 millimole per liter ممكن يكون عنده significant signs and symptoms of the central nervous system dysfunction due to the cerebral edema produced by water entry in the brain tissue down its osmotic gradient. What about the central nervous system dysfunction? It may be manifested by headache, nausea, vomiting, progression to confusion and disorientation, lethargy, coma, and convulsion, and respiratory arrest may develop. Treatment. Except in patients with extracellular fluid volume depletion يعني دول اللي ممكن يتعملهم fluid restriction is recommended. لو الهايبوناتريميا is accompanied by mental changes or if the serum sodium أقل من 120 هبدأ أدي saline administration is recommended. Correction by IV 3%, but caution may be very important for patients with either liver cirrhosis or heart failure وفي الحالة اللي زي دي العيان بيحتاج ان هو يكون admitted لل ICU. treat البوتنشال cause for example لو حاجة endocrine ممكن تتعالج وفي oral V2 receptor antagonist is currently being evaluated in human for its efficiency. What about hypernatremia يعني sodium more than 145 milli equivalent. Causes of hypernatremia يا excess intake و most probably بيبقى iatrogenic through mixed formula للعيان اللي هو بياخد parenteral nutrition أو exogenous عيان بديله bicarb بكمية كبيرة containing sodium أو العيان اللي بياخد hypertonic saline بكميات كبيرة أو إن الكوز بتاع الهايبرناتريميا يكون نتيجة اللي هي الووتر ديفيسيت ودي ممكن تحصل من حالات السنترال والنفروجينيك دايابيتس انسيبيتس الانكريز انسنسبل لاست بحيث ان يبقى الفلويد اللي لاست اكتر من الصوديوم فالعيان يبقى عنده hypernatremia او inadequate intake of the fluid inducing hypernatremia. water and sodium deficit بيحصل لاست للووتر ولاست للصوديوم بس كمية الصوديوم اللي بتبقى لاست قليلة فالنت ريزلت ان يحصل ريتيننج للصوديوم في البلاد فيبان ان العيان عنده hypernatremia. دي ممكن تيجي من الجي اي تي لاس ممكن تيجي من الكيتينيوس لاسس ودي في حالات البيرنز ب هاي ديجري رينال لاس من خلال الاوزموتيك دايوريسيس او الكرونيك كيدني ديزيز او البوليوريك فيز في الاي تي ان او البوست اوبستراكتيف دايوريسيس اللي اتكلمنا عليهم من شويه ان العيان بيبقى بيخش في بوليوريك فيز فيبقى فيه كميه فلويد لاس اكتر من كمية الصوديوم اللي هتبقى lost، فيبان ان هو عنده hypernatremia. ال symptoms of hypernatremia اغلبها ليها علاقة بالديهايدريشن، لان العيان بيبقى فيه fluid loss بكمية اكتر. ممكن يحصل thrombosis زي الرينال فين والفلجورا of the sinuses. ممكن يبقى confusion، ممكن يحصل muscle twitches up to death. التريتمنت it is simply replacing the water. Blood test should be performed every few hours to help determine when the enough fluid has to be stopped. The blood sodium concentration is reduced very slowly because correcting the condition too rapidly ممكن تعمل permanent brain damage. And of course you have to treat the underlying cause to avoid the developing of the condition again.